Please join me in welcoming Dr. Paula Reitz.
Thank you. Thank you very much. Glad to be here. Thanks for the invitation. So, right into the microphone. I'm kind of short. All right. So, I was asked to talk a little bit about what do we know about the relationship between mental health problems and marijuana. And I'm really good. I don't have any conflicts of interest. That I think I've been a researcher doing clinical research in this town almost 2 decades. I'm a child adolescent psychiatrist, addiction psychiatrist, and also been involved in treating kids in this town for about 20 years who are referred to drug treatment mostly for cannabis use disorders and whatever else they're using. So I'm a treatment specialist as well as a clinical researcher. And my research has not been funded by industry, but rather by the National Institute on Drug Abuse. So the objectives here are, I want to give you a sense of what the research shows about this the interrelationships between mental health problems and marijuana use across the developmental spectrum, but I'll really drill down on the impact on youth and prenatal exposure and adolescent brain development, and also some neurocognitive deficits that adults who are chronic, long-time smokers may experience. And then I want to sort of do a research-informed approach to what we might do about that, how we might protect public health and safety in a thoughtful way. So first, I'll start with what we know is for sure is what research has unequivocally told us in the past 20 years is both mental illness and addiction are neurobiologically based medical illnesses, and they are largely pediatric onset, both. That is, about 50% of all psychiatric disorders have an onset before the age of 15. That's half. And about 3/4 have an onset before the age of 24. So again, mental illness is largely pediatric onset, and addiction, most individuals who suffer from addiction in adulthood started using when they were adolescents. And so there's no question about that. And we know that the prevalence of both mental illness and addiction has been rising in young people for more than a decade. It looks like that's a real cohort effect. We're not sure the reasons why, but it looks like the prevalence has been increasing. And we know that as a general rule, childhood onset mental illness or mental health problems increase the risk of developing an adolescent or early onset substance use disorder. And if you develop a substance use disorder in adolescence, that increases your risk significantly of mental health problems arising later. So they're kind of really interrelated. So let me just say what I want to focus on here. I'll focus a little bit on the impact of prenatal, the science we have on prenatal exposure and how that might affect fetal brain development and health risks as it relates to mental health mostly. And then others will talk about how the prevalence of hospitalizations in very young children, infants to preteens, has risen because of inadvertent exposure to marijuana edibles. We don't know how that or if that's related to mental health problems, but we do know, and the science is unequivocal and growing, in adolescence. We know that cannabis is really neurotoxic to adolescent brain development, and it's highly associated, it's unequivocal that it increases risk about 2 to 4 times of psychosis, as well as depression and anxiety disorders in young adulthood. So not immediately. And there's some emerging data from twin studies, very good studies, that indicate that it may increase kids who start smoking marijuana, it may increase their reward response or their vulnerability to addiction to substances tried later. So I'm most concerned about kids, prenatal exposure in adolescence. We also have some research that it is probably deleterious to the development of reproductive system development in adolescent girls, as well as it causes impact on the reproductive system in adults who smoke regularly as well. And can cause, in adults who chronically use and are heavy marijuana users, it certainly causes neurocognitive deficits, memory, short-term memory deficits, decision-making, abstract reasoning. And in chronic smokers, those may persist for at least a month, even after abstinence. But more so in adolescence, we know that regular chronic use in adolescent development is associated with persistent neurocognitive deficits, and those who smoke daily or near daily, certainly a recent study, very good longitudinal study about it, one of the best longitudinal research groups in the world, showed a reduction of 6 to 8 points in adult IQ with that kind of smoking in adolescence. And it's estimated that between 10 and 15% of adolescents or high school students may be smoking at that level. So that's a real public health concern. It's also associated with, if I can go back, with, if you look at the prenatal risk, I want to drill down on this was a study done out of Pittsburgh. They followed the kids from, prenatally to age 14 now, okay? And it was robustly associated with learning deficits. Women who smoked more than one joint per day, and this is back, 16 years ago, versus less than one joint per day. The average was about 3.2 joints per day. Probably the marijuana they were smoking in Pittsburgh 16 years ago was not as potent as the marijuana that we have in Colorado. But nonetheless, it was associated with pretty persistent deficits in learning, reading, abstract reasoning, memory. And the bottom line is those kids had poor academic achievement. It was also associated with a depression onset, early onset depression in these kids, especially in boys, by age 10. That's an important thing for you to kind of hang on to for a minute. So let's drill down on adolescent exposure again. So the relationship between marijuana and mental health problems, the environmental risk factors are similar for both. That is, family, the usual, if there's abuse, neglect, a lot of substance use in the family, or there's major losses or disruptions in family structure, those things are risk factors for not just for mental health problems such as conduct disorder, depression, anxiety disorders, but also significant risks for developing adolescent onset substance abuse. School failure, we haven't paid as much attention as we should in the psychiatric literature to school failure or poor academic performance, but it appears that in itself too is a risk factor. If you're not doing well in school, you're going to be more at risk for hanging out with a more deviant peer group who have more behavior problems, and they're the kids who are going to be in the parking lot smoking marijuana or using drugs. And so that's a pathway, school failure or poor academic performance, a pathway to deviant peer conduct problems and substance abuse based on longitudinal studies. So let me just show you. This slide is put here because I wanted to drive you crazy, and it will. It'll probably be reflected in the evaluations. But it's not for you to remember every one of these arrows or all of that, but I want to show you how complex the relationship is between cannabis and down. Sorry. Can you hear me now? I'll move it closer. All right, so we talked a little bit about prenatal exposure, that increases the risk for early onset depression. It also increases risk for behavior problems. Many of those kids will develop conduct disorder and the learning disabilities, poor academic achievement. All right, that's on the prenatal side. But we also know that poor school performance increases your risk of hanging out with a deviant peer group. These are from very good longitudinal studies, not just one. And that increases your risk of having conduct disorder, and that robustly increases your risk of substance use disorder. We know that about 80 to 85% of kids will experiment with drugs of abuse, including cannabis, before they graduate from high school. Certainly not all of those. A minority of those, they don't progress to have a substance problem, right? Who does? It's the kids who have risk factors in these domains. And so we can see that coming a mile away. We better be able to train our clinicians to identify these risk factors, because there are interventions when you see it coming that can prevent or at least reduce the risk in kids. So we also know that the relationship conduct disorder leads to depression. Depression is associated with having behavior problems, and if they start using marijuana, there's a specific study that shows that leads to riskier sex. We don't know the causal relationship. We just know that they use condoms less frequently, they have more sexual partners, and more likely early onset pregnancy. So if you had none of these risk factors and you just started smoking marijuana and you're an adolescent, and it's a period of brain development from about 10 into your mid to late 20s, your brain's under construction in a big way. And I'll talk about why we think it's so neurotoxic to brain development, but basically, marijuana, probably more regular use amongst adolescents, is associated with increasing your risk of depression and anxiety and disorders in young adulthood, but unequivocally increases your risk of developing psychosis, perhaps precipitating an earlier onset of schizophrenia in people who were at risk for developing schizophrenia in the first place. But the earlier onset of that serious mental illness is a poorer prognosis than later onset. But it also looks like cannabis may cause psychosis by different mechanisms in individuals who may not be at risk for schizophrenia. That is, it interferes with the development of, glutamate pathway development, dopamine and GABAergic pathway development, because the cannabis receptor, the CB1 receptor, that THC sits on if you're smoking marijuana, is critically involved in regulating the development of the business end of our brains, the prefrontal cortex. So let's just talk a little bit about adolescent brain development. What's the big deal? It matters what kids are involved with during their adolescent development. That is, the predominant activities that adolescents, kind of environment and activities that they're involved with during adolescent brain development affects the way the brain develops forever. That is, it's not going to be this simple. I'm going to oversimplify. It's not as simple as use it or lose it. But what's occurring during this period from 10 to mid to late 20s is synaptic pruning. You're pruning away synapses and neural pathways that really aren't being used much, and you're refining and making more efficient those that you really need and are utilized. So it looks like, so what happens if a kid is predominantly involved in doing physics problems, math problems, and going to school and piano lessons? That's a different brain development path. If you're predominantly in the parking lot smoking marijuana and you're spending more of your time hanging out with a deviant peer group and you're being truant or expelled from school. So it impacts the way your brain develops because we think predominantly because of the CB1 receptor being so critically involved in regulating the development of the prefrontal cortex. So let's just move to back to this overview. So what can we do to kind of summarize this? And what am I most concerned with, and where are the biggest gaps? What do we need to do to protect, especially our youth and families, from the impact of this neurotoxic substance that we have, we've rolled it out and legalized. 5 minutes, I'm good. All right, so basically, we know that about 1 in 6, we know that 1 out of 11, adults who try marijuana will progress to dependence, kind of get in trouble with it, progress to maybe daily or near daily smoking. That's not everybody, but it's about 1 in 11. So the research shows it looks like adolescents are more vulnerable. 1 out of 6 adolescents who experiments progresses to dependence, cannabis dependence. That means daily or near daily smoking, or at least more than 20 days out of the month. And that is the level of smoking that has been associated with a reduction of 6 to 8 points in IQ, in adult IQ, and persistent neurocognitive deficits that appear may not be fully reversible even with abstinence. And there's 3 studies, not 1 study, that kind of it converges on this. So I'm concerned about that. I'm concerned that we'll see more emergency room visits. Certainly emergency room docs are talking about increased prevalence of cannabis-induced hyperemesis syndrome, right? And also motor vehicle accidents. But let's just focus down on youth, and that is I'm worried that we'll have more exposure, inadvertent exposures in young children, because the edibles are packaged in ways that are very appealing, jelly beans and brownies and lollipops. I'm concerned about that, and I'm concerned that recent research from our division faculty members looking at the effects of medical marijuana showed that 40% of new users are women, the majority of whom are in childbearing age years, and so I'm concerned about prenatal exposure and that the resources that it'll take for special education. So let me just summarize in adolescence. That's where I'm really the most concerned because we don't have adequate access or availability of treatment for these kids, And again, we have evidence-based prevention in our schools, many of our schools. We really don't have adequate treatment. What can we do in Colorado to reduce the mental health risks and protect public safety? One thing is for sure, we got to develop and implement effective and developmentally tailored programs and messaging to increase public education and awareness about the science, okay? We'll probably do a pretty good job. And what I mean by public developmentally tailored is that the messaging to kids is going to be different from the messaging to young adults and the messaging to older adults about the risks. We've got to do a really thoughtful job about regulatory policy and procedures that effectively protect public health. But the third one, if I'm asked what are the biggest gaps, is this: we've got to increase access and availability, not to mention third-party payers and adequate compensation for highly trained clinicians who are trained in evidence-based practices. And we need, when I say we need to increase access and availability of treatment for our adolescents, this is what I mean. This is the most depressing slide I have seen throughout my entire career, and this existed before we legalized marijuana in Colorado. SAMHSA publishes this every year, and they say fewer than 10% of adolescents who could benefit from drug treatment receive it. Less than 10%. And largely, we think that that's an artifact of the third-party payer system. That is, most kids who are in drug treatment and community-based treatment programs are referred by juvenile justice, and they pay for that treatment, thank God. But the problem is, where are the other 90% that we're not reaching? And they're in our high schools, right? They're in our high schools. 10 to 15% of our kids who have severe cannabis use disorders and other drug problems are in our schools. So we better get in there, because currently in our schools, we have programs that are largely designed for kids who don't use or who have limited exposure. And we really need to adapt some of our real evidence-based with proven efficacy treatments to bring them into the schools and really help these kids. We've just recently done that with our partner in Adams City High School. I've devoted my career to developing integrated mental health substance treatment, right? And so we've moved it into Adams City. Every single kid who is referred to me in Adams City for a school-related drug and alcohol offense has had rip-roaring cannabis dependence, using at levels as serious as I've ever seen in community-based treatment programs, 2 to 4 grams a day, many of them from the age of 13, and now they're 15, 16. It's really concerning, because in 2008, drug-related suspensions, expulsions from high school were at an 8-year low. Since 2009, we've seen big increases, significant increases, most of them related to marijuana. And we know that nationwide, we've got rising rates of marijuana use, but in Colorado, we know that our rates are higher than the national level. So I would urge us to really be thoughtful about we've got to all roll up our sleeves and protect our youth. And I'll stop there. Thank you. Thank you.
Thank you.
Questions?
Questions from the panel?
I wanted to thank you actually for putting up that very busy slide, because I think it really illustrates how complicated this issue is. And, you know, when we look at after birth, the role of nutrition and economics and education and family and all of these things that also impact the decisions to use substances and all of that. So my question is actually about drug education.
Right.
So, you know, a lot of the federal funding that comes out for drug education is for abstinence-based education with the message of just stay away from drugs. So my question is, given that, you know, obviously teens are experimenting and that now they're in an environment where there's a regulation around marijuana, should we be shifting more towards how we talk about alcohol, where the message is more delay, 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 rather than never use? And do you think that would be more helpful in, you know, kind of providing this more evidence-based than just say,
Sure.
no, you know, hands off?
Well, certainly, you know, whatever the adults are doing in society, that's what the kids are going to be doing, right? So I'm concerned that we've sent a message to our kids about that they're going to have a decreased perception of risk. And so the science doesn't match up with that. So delaying it, certainly, if you said delay, 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 there's certainly studies that show that individuals who start smoking marijuana after the age of 17, as opposed to before the age of 17, do not have the persistent neurocognitive deficits and problems that the kids who start earlier are. So certainly harm reduction, delay, delay, delay. Adults who smoke regularly, they got neurocognitive deficits too if they're smoking chronically and heavily, but at least most of those clear in a month, and the kids, they don't clear. So I think that's one message. I'm all about harm reduction if we don't get abstinence.
Other questions from the panel?
Thank you for your attention.
Let me ask a question, since we do have a minute.
Sure.
So I've only started looking at this literature within the last 2 or 3 weeks, to tell you the truth.
Yeah.
And I'm always impressed by a couple things. One is that the discussion in the mental health literature always includes these caveats about self-medication, about the fact that different drugs can be used as a self-medicating device before the diagnosis of a mental illness. It wouldn't be a fair question to ask you what proportion of this risk that you describe is due to that, but I'm going to ask you anyhow. I mean, obviously you don't know, and I don't know, and the people who write these papers don't know. There's clearly a contribution of self-medication, but do you have a gut feeling for how much of that explains some of these relationships?
Kids say that all the time, so do adults. And perception, it may be true. So here's the deal with self-medication. And there's I see kids all the time who had depression and they escalated their marijuana use like, oh my God, I can't tolerate my life, right? Well, the one thing is marijuana does not treat depression, so in that way it's not medication. We have treatments that work for depression and marijuana is not one of them, right? So, but I have no doubt that people do it to alleviate symptoms of their mental health problem or coping or whatever. I have no doubt. But here's the deal. And the research, including my own but others, has shown that once you've got a cannabis use disorder or any substance use disorder and you have major depression, anxiety disorder, you got two things going on. For example, the studies that I've done and others have done, if you just treat the mental illness, so now you're diagnosing it, the drug use doesn't go away. It doesn't remit because, oh, thank God, now I'm on Prozac or something, and now I can stop smoking marijuana. That doesn't happen. Because now you have the drug itself as a reinforcer, and you've got to address both. And if you don't, the outcomes are poorer. But if you proceed, whether it started with self-medication or it didn't, you got to treat both. And we have evidence-based treatments for depression, anxiety disorders, attention deficit hyperactivity disorder, post-traumatic stress disorder, and we can use those treatments, but marijuana doesn't treat any of those psychiatric disorders.
Great. Thank you very much. Any other questions?